visible?
Not yet, sir. You start now. You present it now.
Is
Go
it
to the.
okay?
Yeah,
Can you see the?
I can
Can you
see
see
you,
the?
but you start the present now. Present now button.
Okay. Okay.
The way you started before. I can see you, but you start the presenting button. It's getting recorded now.
Is it okay?
Yes, sir.
Should I start?
Yes, sir. Yes, sir.
So I was talking about that. I felt, what should I talk about? Then the list was given to me about the kind of surgeries that they would like to see. So I'll just give a little introduction of how we started our humble beginning from the valley, in the valley. So after my return from the foreign assignment, I joined a very small place. I hope you can see this. This is a very small place in the lap of a jungle. Most of you who must have traveled to Kashmir know this place. They have seen this. This is a beautiful place, a heaven in the heaven. That's Gulmarg. In the downscape slice of the lap of this Gulmarg, you have a hospital called the sub-district hospital of a level of this. 2003, I joined this place as assistant surgeon, and I started my work over there. Slowly, I started presenting and my work all over the country, the kind of work that we could do in this small hospital. And meanwhile, around 2004, I went ahead with a fellowship of minimal access surgery and got it from the Chennai, and started working as a minimal access surgeon. So we did a workshop. I mean, that was a news that time in 2006 to do. We did a live operative workshop in the countryside. I mean, in this place, sub-district hospital. And meanwhile, the work that we kept on doing, I kept on presenting this work all across the country and started publishing. So you can see that different stalwarts teachers by whom acknowledge them as my teachers. I've kept on learning from all of them. And this is the place which I joined around 2007. I hope Dr. Ibrahim remembers the days because he was with us also for some time. This is the place where I have grown as a medical student. This is Government Medical College, Srinagar, and where I am now a teacher. So it was a privilege to get a place here in faculty. You can see this is the kind of humble contribution, the kind of work that we have been doing, and our contributions to the minimal access surgery. So much of this has been already introduced by Dr. Ibrahim to all of you. So I'll not take time to talk about all this, but we'll see a few videos which will tell you the kind of work that how we have done and how we have modified the conventional techniques in minimal access surgery for the patient benefit. So I will just concise, and I will just take you to the newer horizons in laparoscopic surgery. Though my aim is not to present one single topic, so I'll tell you that what all is possible by laparoscopic surgery as of now. As we all understand that we are stepping into a newer horizons of robotic surgery, and I don't know how many of the senior people in this faculty will agree with me when I say that there is nothing like a super specialization in surgery. I believe the future surgeon is something like a laparoscopic, endoscopic, robotic surgeon, because there is so much of merging of the techniques that are being taken. This is my feeling and this is my, opinion, and I'm giving it to the postgraduates and our outgoing young graduates, that when they will land into this step into this surgery, they will find themselves, they have to be abreast in whatever branch they take. They have to be acquainted with laparoscopic, endoscopic, and robotic surgery. So the future of the surgery is what I have said. So, but there is a feeling among, I'm sorry to say that people from the medicine, they feel that surgeons are just, they stitch and they cut. That's not the truth. Yes, that is truth only if you are working with your hands. Then you probably are what they say to you. You are a laborer. But if you wed your hand with your head, then you are a total craftsman. And that's what a surgeon is. You are a craftsman. So you have to be apply as per your own knowledge, your own setup and infrastructure. You have to modify the given current techniques and be creative in your field. And this is because of the creativity that we have set a house on the Mars. And I don't know, I mean, the time is not far when we will book the land on Mars. So these innovations are important. They may be very humble, they may be small, but if they help in different segments of treatment of the patient plan, they are worth describing. They are worth appreciating and applauding. So you can see that we started somewhere here. If you could see this. Sir, am I audible? Is it?
Yes, sir. Yes, sir. Everything is going on nicely.
Fine, fine. So I was saying that
our principal has joined us. We welcome him.
Thank you very much. Thank you very much. I am honored he has joined us.
Sir. He's a head of the unit surgery. He's himself a great surgeon here.
Thank you.
We are honored to have him.
Thank you.
Continue.
So what I was saying that these modifications and innovations of time, we started surgery somewhere here, and this was the armamentarium, the surgical armamentarium. Remember the days when they would lie the patient on the, without anesthesia, and people would hold his hands, and the surgeon, you could see this was the kind of gadgetry that we worked. But thanks to the time, thanks to the innovations, thanks to the newer concepts that we grew into a kind of surgery that we do, that's where you have an incision, you have an open surgery, which we practice still now, but this open surgery is getting replaced to the buttonhole surgery or the keyhole surgery. You can see now we have only the spots in this, and any surgery is possible by this method. We call this minimal access surgery or the laparoscopic surgery. And you can see the current scenario in surgery is that Robert is planned there. This is basically tuned to do the surgery, and the surgeon sits somewhere at the console and the surgeon does the surgery. So this has been only possible, and thanks to the time and the evolution tree in the surgery, this is just how the surgery has developed. And I must acknowledge, and I must say that we need to give standing ovation to this Department of Science and Technology. You see, everything is getting replaced by metal. Now in your body, everything is wet. You take any specialty. I don't know what future man would be looking like. We are just left with the transplant of the brain. Rest, we are almost metal, and metal everywhere. So the current surgeon, the future of surgery is that you have to get acquainted with the science and technology. It's a marriage between the medical science and the medical and scientific technology that has resulted into this current scenario where we are in. I should say that I am really, really inspired, and I wanted to share this slide with all of you. We must not say every mistake is a foolish one. And when I look at this, what this man, this great man, Cicero, he said very long back from time immemorial. I mean, this is my inspiration, that where from the innovations, where from the new concepts come, we just appreciate, and we have to learn from our mistakes. That is, and understand that whenever we are in bad times, tough times, we need to understand that we have smiles and tears, ups and downs. We have to understand that at the end of the tunnel, you never lose hope when you are into that work of innovations, you are into that work of propagating the newer concepts. I don't know, most of the postgraduates in surgery know the people who propagated this minimal access surgery, the kind of the fate they were fed up with. I mean, then we today call them as the pioneers of the surgery, the fathers of this concept of minimal access surgery. So if you go to the International Journal of Surgery, PubMed, Elsevier is the biggest house. I stand one of the editors, assistant editors for that, and also a reviewer. We have published our concepts when I was working. I mean, I did not have a say into, there is a way to grow in medical colleges, as all of you, your senior people will have the say. There is one system at the time when I was working. So what will happen that I was working with as an open surgery, though I was trained in laparoscopy, but I did not have an access to the laparoscopic surgeon. So what happened that we made a technique on our name, the Chalkoo innovation, which is PubMed referenced by 28 journals now. And you see, this was the kind of gadgets, and many surgeons, do this. But how did we make it different? That we tried to do this kind of surgery. This was in open surgery and oblique incision, which stands here in the subcostal region, and trying to do the surgery all through the two artery clips, and it is the index finger that does the job. And how do we take the knot over there? I mean, this all went, and the work you can see at the end of the day, it looks like as there is just a big epigastric port and nothing more. So even if you are doing an open surgery, there are the ways that you can reduce the surgical trauma, and this is what we kept on publishing, and that is the technique in this. So you would be glad to know that we tried our hard to then subsequently we felt we should have an instrument, something like this. We propagated and conceptualized. 2013 we applied for this concept, and this is a small retractor on our name, and this helps. The idea of this retractor is that you just have a blade which goes through 2 centimeter incision for cholecystectomy, and when you open it, it opens like 2, 2, and 2, that is 6 centimeters, and it gives you a 6 centimeters retraction in the Morrison's pouch, where you are trying to make your assistant is trying to make your surgeon comfortable to proceed for. So this we patented this instrument and carried on the job. Subsequently, we took to the laparoscopic surgery. So as of now, we only purely believe that that is the standard of treatment for cholecystectomy, and we kept on publishing. This is one of our publications, the modifications and innovations with our name, and it's highly referenced paper, and it was considered as the top 10 papers in 2012. So we kept on getting the invitations from China, we kept on getting invitations from Turkey, Italy to present this innovation, the Hong Kong, Dubai, Malaysia, and we kept on presenting in different countries. So we also presented our newer concepts in hysterectomy. You will be surprised to know, and though as surgeons, we are not, allowed to perform hysterectomy, but I have a different idea, because if you make a procedure, more smarter for the patient, more acceptable vis-a-vis reducing the surgical trauma, those were the concepts which we proposed, and Hogsey made it as one of the best papers in the field of gynecology. The idea of this paper was how to make the hysterectomy simpler and simpler. You can see in 2013, we had a World Congress, and it was an honor to be straddle the shoulders with these pioneers of different specialties of surgery. Professor Ozrensky is here. He has 17 patents, and I was invited as an organizing committee member, and to deliver a keynote on my innovations. So we kept on going ahead and got an appreciation letter for this innovation from the department of, from our health and medical education department. And as already said, we got contributed in the world's who is who. The contributions are mentioned there, the 2015 edition. So now, as all of you know, the students and postgraduates will agree with me that this is what has cropped up into our theaters now. These are the gadgets, these are the staplers, and we have to get equipped. This thing with the hand using the needle holder is falling short of now. I mean, we don't see much of this, and this is what they should be acquainted and taught with, because this is the future of their surgery. These staplers, they have done a wonderful job. They have reduced the time, the precision, and yes, cost is a concern, but they are cost effective. Cost effective is a term that is used in surgery. So I would just take you to a video. This is what a video of our modification of 3-port. We modified the 4-port technique to 3-port, but we modified the 3-port in a way that you just stay with the video. I'll just start the video. So you see you have a 4-port convention, you have 3-port, you have 2-port, you have sills. But how do we do this? We'll show you that. This is a patient. We are making an umbilicus incision. We go transumbilical. The reason to go transumbilical is that there is no scar. If you have an intraumbilical port here, first optical port, you will have a scar there. So transumbilical is little difficult, but it is, I mean, it saves a scar over the abdomen. So we are doing a Verese technique here, and after doing a Verese technique, we make sure that it freely flows. You have a saline drop test. You have all the tests. You have insufflation test. You have the percussion test. So all these tests, once you are sure that you have gone to the peritoneal abdominal cavity, the Verese needle is inside, you check the pressure. The 15 pressure should be around 12 to 15. And then you see the flow. And then you first stroke, or we make it in the umbilicus, that is the umbilical, the optical trocar, attach the gas pipe to it, and you will see that. Now, what are we going to do after this? I'm just going to tell you what is Chalkoo's point, as was earlier referenced in my introduction. What is that, Chalkoo's point? That is that we make epigastric port. When we wanted to make the epigastric port, the books mention that where should it exactly be made? There is no mention. You see how we make it. We put the index finger on the 9th costal cartilage of the left hand and the thumb at the epigastrum. This is exactly our point of epigastric point, because if you go a little high up or little down, you will find difficulty. Even if the expert surgeon is there, we have religiously seen with our experience that if you make epigastric port at this point, that is the point is we make by our name as Chalkoo's point, which is published. So what I keep on teaching my postgraduates at this point, when we see why should we make it there in the center, that if you go little medial, you will injure the branches of the epigastric artery. So you can see this is what we all do. But here, what is my point, that this is really important, that epigastric port is the most important port, where exactly it should be made. It should be made, and the maneuver, the way I have shown you, should be done, because our postgraduates and registrars, they practice this port here, and they find it very interesting and very, pleasurable. Surgery becomes pleasure. It's a 10 mm port. You can put an endoscope here to check whether this port was right. Now you see what is my idea is that where we have made the third port. This is a 5 mm left-hand port. I make it at 8 o'clock in the umbilicus so that this port is not seen. So the fourth port we avoid. We don't make it here. That leaves a scar. So you can see we are working here. And this is ergonomically also, ergonomically it suits. You are not crossing so there are two advantages. You are not crossing to the opposite side, and you are on the same side. It's like driving the player of the, the vehicle. So you are working like this. So these are the port positions of and this modification is published in the, International Journal of Surgery, published from elsewhere. We published it in 2013, and we are religiously carrying this kind of port position for our cholecystectomy. We handle almost all kinds of gallbladders, cholecystectomies in this position. So you can see the cameraman and this, there is no fighting between the two, and you can see how does it look like, and on the screen you can see the surgeon is working. This is inside the endo view I am taking. How does it look like inside? So you are this is your left port and this is the right port. You go to open the Carrett's triangle. So you can see you can open the Carrett's triangle. Slowly you go to the posterior peritoneum. So open the posterior window, make a very good, go to the anterior window, make an anterior window, and then you can, you can make with this. The cameraman here has to be very tricky. He should know how to handle the camera. If you're working with 30 degree, that would be better, because you can have an option of seeing the posterior window, anterior window, and your cameraman should know how to show you. We are milking the cystic duct. I'll just take the video a little ahead, and we are clipping. So everything has to be done. Your left hand is doing both jobs of the retraction as well as holding, and we'll put a clip in the cystic duct. We go little ahead, another clip is put, and then you cut. Sorry, I'll go back. Fine. So I'll take you to the video. I was here. So we is it seen? Fine. So we have put the clips and we will cut the cystic duct in between. This is one of the very old videos, almost 10 years old video. I don't know how does it look like. So you can see everything is done by the right hand. Left hand only holds. So what is important that you have to develop both hands in laparoscopic surgery, as you all know. Then we will take the gallbladder up and remove the gallbladder. So this is another patient. You can see such a difficult gallbladder, looks difficult because it is contracted, fibrosed, and you can see that we are doing it by the same technique, the 3-port technique. So you go to the callets, you cannot see the callets here. It is something like frozen, but we're managing with the 2 ports only. I mean, the working 2 ports with the position port position, which you know. Sorry. So I will just add this video, add this part, right? So we are taking the, putting the clips. The cystic duct is delineated. Now, what is the advantage of this technique is that you can only see at the end of the day only 1 port, that is the epigastric port is seen. So as if you have done a single port technique, that is you are avoiding 4, the scars over the abdomen. I would not say that 4 mm port may develop pain. You have less pain, or that's possibly 4 mm ports do not give much pain. It's only 10 mm port. Yes, the hernias again 10 mm ports, but you are reducing the number of ports and doing the same job what can be done by 4 ports. So you can see that we have removed the gallbladder, and slowly you can see the bed is there. We have seen this all is done by this technique, a modified 3-port technique. So, and this is the Indian Journal of Surgery, which is again PubMed. We questioned this. Is 4th port really required in laparoscopic cholecystectomy? We published this and presented this modification. Right. I feel there is some browsing going on. Right. So you can see this is a publication of this 3-port, a medical school experience with 3-port with new modification in technique. We publish it in Elsevier. This is a PubMed and highly referenced paper. If you see the post-operative position, you can see this is the epigastric scar. This is how it looks like at 3 months. You see, you can't find the the port through the umbilicus because it's itself a scar. And you can see after 3 months, you only find there is 1 scar at the epigastrium. It looks like as if this is the position at the 3rd month. This is post-operative position of this patient operated by this technique. Now, there was a point. What was the concept? Why did we have a concept of Chalkoo's point? It was not just being in the news that we have a point on our name. This was because you all understand that epigastrium is a country. It is where exactly should we make it? So when we go to the literature, they will tell you make it in the subxiphoid area. If you see what is subxiphoid, subxiphoid is again a big village. So where exactly should we make this point? And this thing happened when we give it to our registrars or junior consultants. They will tell you, sir, where exactly should we make this port? So to make this port at a position where it should be, that was the idea. We felt, no, we should give it a proper address. Like it is Dr. Chalkoo's house, it is the India, it is J&K, it is Srinagar, it is Hyderpura, it is Gulbarga Colony, it is Sector 1. And so that was the idea of creation of this port. Now you can see we devised a method. You take a mid-sternal line which passes through the umbilicus. You make another line, the mid-clavicular line. So you will see that you take a line at the tip of the 9th costal cartilage. I put my index finger of left hand and straddle the thumb on this and take a line on this. The line where it intersects the sternal line, the mid-sternal line, is the point where exactly we should make and we have religiously performed more than 500 cholecystectomies. I think more than that. We have seen that this port position here makes you quite comfortable. And we have shown you the way how this port should be made. And you try it, this exactly making here, you will find that if you go little 1 centimeter up and down than this, you will find difficulty in handling the gallbladder, even if a surgeon is very expert. So our observations were it is very easy to locate this point. It adds safety, it adds speed to the procedure, it causes less bleeds. The reason is because when you are in the midline, you are not injuring the epigastric vessels. It needs less thrust because you are going through you're not going through the muscle, you are going through the linea alba only. so there is less bleeding. It usually falls to the right of the falciform ligament. You will try to maintain a 60-degree position of the trocar with the body. It is easy to be learned, it is easy to be taught, and easy to be practiced by young surgeons. So that we published it, and this is again published on our name as our point. So we were interested to see that people are interested. I mean, 6 months after our publication, there is another author put up that what is the appropriate position of epigastric port. So we felt that we are not wasting time in giving you the exact address where exactly should the epigastric port be made. And why only epigastric port we are bothered? Because it's the most important port. It's the right hand port, and the maximum things are done by this. So this port has to be ergonomically suited for the better patient outcome, for safe outcome of the surgery. Now, these are the procedures which we have been doing. So laparoscopic fundoplication is being done. We do it by 4 ports. You can see the ports are there. So this is what we do currently. And you see we took up a research in the colonic tumors, and we published our research in laparoscopic colorectal surgeries, our observations and our outcome. You see it's again done by 3 ports. The 4th port, you make a small incision exactly like you make for appendix, and remove the 3 to 4 centimeter incision is enough to remove the colon. So this is the specimen of the right ascending colon for the ascending colon tumor. So this is again done by laparoscopic technique. We are doing pyeloplasties. So pyeloplasties, it should be a gold standard. We don't do lumbotomy incisions. We do it by 3 ports. You can go by transperitoneal approach, or you can go by a retroperitoneal approach. We perform it both ways, the transperitoneal as well as the retroperitoneum, the laparoscopic pyeloplasty for PUG obstruction. This is an extended hemicolectomy, where we have delivered the specimen out, and extracorporeally you can make the anastomosis. This is yesterday we had a talk on the management of, we had a webinar talk yesterday on the D2 gastrectomy laparoscopic, and we are doing laparoscopic D2 gastrectomies. We have done quite a good number of these patients, and we have been into these advanced procedures since 2011, and till now we have been doing all these procedures laparoscopically. You can see the small incision over here through which the stomach is removed. We do partial, distal, total laparoscopic gastrectomy with Rho and Y gastric. This all is done. I would request all the final year students and postgraduates kindly log in and subscribe to our channel. These all videos are published there, and any video you want to see, you can see them. And there is a detailing of the step-by-step approach of these procedures, advanced procedures. Now, this is a procedure I think most of you must have seen and you must be doing in your department. This is intraperitoneal only mesh hernioplasty. We have IPOM plus. We do IPOM plus to a defect of around 5 to 6 centimeters. We do ETEP, RS, rhizostopa, and we are now going into TAR also. We have done 1 or 2 cases of TAR recently also with a good outcome. So you can see this is a lady who came to us. She had 3-4 laparotomies done. You can see she had 2 LSCS. There was just a map of Jammu and Kashmir made on her abdomen wall. You see how ugly scars, and she came with a very dirty incisional hernia, and she was afraid to go to an open surgeon because it would be a disaster if you open her again through the same incision. So we performed a laparoscopic IPOM plus on this. We already published a research on IPOM plus. One of my postgraduates has worked in this. We have already done around 100 cases of IPOM plus, and you can see only 1, 2, and 3 ports. This hernia we managed by laparoscopic IPOM. Now, there is this technique, all of you must be acquainted with. This is a stapled hemorrhoidectomy, and you can see these are the angry hemorrhoids, which are good for this technique, which you call as stapled hemorrhoidectomy, is performed by the circular stapler kind of. So these are this is the stapler. We do these procedures through stapled hemorrhoidectomy. And it was an honor in Worldcon 2017. I was again invited to demonstrate this technique of stapled hemorrhoidectomy to a crowd of 350 surgeons all across the country and the globe. And this is the pioneer, Professor Antonio Longo from Italy. He was chairing the session and I was operating. I mean, that was an honor for a person like me to get, applauded and acknowledged. And we delivered this we showed them the technique of stapled hemorrhoidectomy. And before I would take you to the video to show you how should we go ahead with the video, I would just take this. I'll take the presentation down. I'll show you. Just want to share this video with you. This is how we have done another modification of two-port technique. So here we are not using the third port. This is a two-port technique, and we are using here. This is again our modification. We are using here. The optical port is same, the epigastric port is same, but we are not using the third port. We are using a port closure needle. So this is the port that has gone, the epigastric port. Am I audible, sir?
Yes, sir. Yes, sir.
Fine. So I was telling you, we have modified the third port, which you could see in the earlier video, was put at the 8 o'clock position at the umbilicus. We modified. We are only putting this needle, which is called the shoemaker needle or the port closure needle, which you all know we use for the port closure. How do we use this needle? But this is very traumatic, so you have to be very sure how do you use it. We use it as a left hand to hold this. This will avoid our two ports, and you will all be. This is better than puppet technique. We will not need to take the sutures. For the beginners, if they do know how to take sutures, it is better for them to need. So just hold this. The maximum job is done by this technique. You can see that we are going to the Callet's triangle and opening the Callet's triangle, holding the gallbladder by this. But make sure that this needle should be always kept in vision. So make sure your cameraman is your friend. He makes you always, allows you to see this needle there. So you can see this needle, we hold the infundibular pouch and dissect the Callet's triangle, open the posterior triangle, you can see. So after we open the posterior triangle, we will dissect. I'll take the video a little faster ahead. I want to share more and more videos with you. That's my idea. So how we do it, that we open this is the cystic duct. So my job, the job is done by your right hand. Left hand is just a supportive hand. So you are avoiding two ports in this patient. It is a two-port technique with an assistance from the port closure. People have used different things. Instead of these, you can go to the literature to see the people are using different things. Like they don't use port closure. They may use some other instruments are using, which are less traumatic, because you have to make 5 mm port. This is just 2 mm port, or you can say its scar does not stay there. So this is the Callet's triangle open. So we go ahead and dissect. This is the cystic duct is open, and we're milking it to make sure. We are taking a suture and doing a single hand suturing. I hope you can appreciate the single hand suturing. This is Shalabi and Ismail patent, people from Egypt, who devised this single hand technique of suturing. You see, the second hand is not involved. You can see you make a loop with a single hand, make a loop and go to hold this loop. You can appreciate this, what we are doing, and the other person from outside, the other tail end of the suture remains formless. He will pull and you will also pull. Do a traction and counter traction. You can see we are doing this intracorporeal suturing. You are not finding the other hand there. So this is a single hand suturing. This single hand suturing is more important when you will be doing the GI surgery, because in colectomies you will have only 2 hands available. So you will have to hold the bleeder on one hand and do suturing by one hand only. So you have to get trained to handle those exigencies in surgery. So that's how we do the single hand knotting and suturing. So after this, we will put a clip. This was just to demonstrate you how the single hand suturing is done. So we'll put another clip, and then we will cut the gallbladder. So the cystic duct, you can see it has been cut, and we are taking the cystic artery and clipping it, and then we take the gallbladder up. I'll stop this here, but I'll go to show you an interesting video which you wanted to see, as I was told by the list which was provided to me, because you will not see this surgery quite often, because we have now wonderful gastroenterologists with us. This is truncal vagotomy being done laparoscopically. So what you do is that you do it by 5 ports. The port that is in the epigastrium is holding the left lobe of the liver. You can see this is the gastroesophageal junction. This was a male who was chronic duodenal ulcer, We don't get these vagotomies now because we have good drugs, PPIs available. We all the complications, and if there is a benign gastric outlet obstruction, I think gastroenterologists do balloon dilatation. They don't leave it to surgeons now. But this patient was twice balloon dilatation was tried. He had a benign gastric outlet obstruction, and he was referred to us for doing the vagotomy with the drainage procedure, and drainage procedure we did in this was gastrojejunostomy. So that's the reason, because I felt this could be interesting for you, because postgraduates don't see vagotomy now, because I remember vagotomy we used to see in our days in medical college when I was a resident of surgery somewhere long back in 90s, late 90s. So you see what are we doing is, this is the gastroesophageal junction, this is the hiatus esophagus. I have cut the pars flaccida, and as I go up, I will cut the pars densa. So once you open the pars flaccida and pars densa, you are opening the lesser sac on this side. This is the gastrohepatic ligament. Now what we do is we go all across the phrenoesophageal. You can see this white structure over here. This is phrenoesophageal membrane that will run all across the esophagus. So we are approaching the gastroesophageal junction. At this part, we should see the crust. Can you see this down there? This is the crust, the right crust of the diaphragm. So we are cutting, this is the harmonic in my right hand, and left hand has the grasper. This is the retractor, the fan-shaped retractor. The assistant holds the left lobe, and we're trying to go all across, cutting the phrenoesophageal ligament. You can see all these videos on my channel on YouTube. If you subscribe to YouTube, you will see all these procedures, the gastrectomies, partial, total, esophagogastrectomy. Then you will see the vagotomies and all that. You will see them in detail. So some of the fat we are cutting over here to gain an access down there. Posteriorly, you will have a pancreas. So here what we are doing is that we are just lifting this fat and trying to see where exactly we have to go. Kindly make sure that you have to first delineate. This is the crust, and this is the fascia over this crust. So you have to develop a space between the right crust. This is the right crust of the diaphragm, and this is the plane which we need to open. That is the plane between the right crust and the diaphragm. So with the left hand, you can open this plane very gently, because you have to see the right vagus. The right vagus is always anterior, and left vagus is right is posterior, sorry, and the left is anterior. So this is the right vagus. We are searching for the right vagus. Right is anterior. This will be anterior. Sorry, right is posterior. So this is the right vagus I am searching. So I'm opening this cleavage. So what is very important, that you are doing a truncal vagotomy here. If you have to do selective or highly selective, you have to go to down, kind of seromyotomy you do. But here we're doing a truncal vagotomy. We're searching for vagus. This is a tricky nerve that you have to be very meticulous, avoid bleeding over there, then probably you will miss it. So you have to be very gentle and tease these structures between the right crust of the diaphragm and the esophagus. In a short while, you'll see we have crossed the phrenoesophageal ligament, and we are trying to grope the space between the right crest of the diaphragm and the esophagus. And as you go ahead, you will see we are teasing these structures. Gently you tease them and try to see any cord-like structure is coming or not. You will find that this is little away from the esophagus, because this is the right vagus, this is posteriorly placed. So you can see possibly this could be vagus. No, it is not. So we will dissect it a little further up. And in a short while now, you can see we have dissected. I have gone little ahead. And you will see that here you will find a structure like this. Could this be vagus? Let us see. No, this is not. Because you will feel there is some tactile feedback by laparoscopy also. You will find it's a taut structure that lies in this plane, slightly away from the esophagus. Now you can see in a short while now, you'll see how this vagus looks like. I remember in my times we had open surgeons. They used to take it out. There was a technique to identify the vagus, but now laparoscopically it is even more easy. if you see. Now you can see this white structure. I hope you can appreciate. This is the vagus. You can see this white. This is the right vagus, that is posterior. You can see this is the right vagus, and this is a taut. Now, how can you confirm that this is vagus? You just take it up and do a traction. I will just take little fibers of this rhinoesophageal membrane and the fat out and tease it out to show you where exactly is the vagus. So you have opened it. You can see this I'm trying to clean. There's some amount of blood over there, but you can see the blood loss. Blood loss is so minimal. If you have to do this procedure, you will have to do almost a double subcostal. You can see this is vagus going down. I'm trying to pull it, and now this is the posterior vagus, or this is the right vagus, and we have to do bilateral truncal vagotomy in this patient. We have picked up the right vagus. In a short while now, it will be more clear to you that this is exactly the vagus. If you pull it, there should be a traction being seen going down. So it goes down. It gives a celiac branch over here. It gives then gastric branches, and it turns to the pylorus as the nerve of Latorget. So you have to take the trunk. If you take the trunk here, this is the main trunk of the vagus nerve. So we will put the clips and do cut this vagus. In my left hand, I hold the vagus, and in my right hand, I'm entering through Feynman port and putting a clip down distally also, and this. You can cauterize it, but there is always a vasa vasorum as a vasa nervosum. So it is better to put a clip and cut a segment of the nerve and send it for biopsy. You will be sure that the pathologist will report it as a nerve only. Some neural sheath will be there, nerve fiber will be there, and then you can see now we have removed the right vagus. Now we are going across the. This is the diaphragm. You can see here. This is the musculus muscle of the diaphragm. This is the central tendon of the diaphragm, and this is the esophageal hiatus. We have opened the hiatus, and we are trying to now grope for the left vagus. Left is anterior, so it will be anteriorly placed in the esophagus, and left vagus will also give the branch, the celiac branch, the gastric branches, and it will terminate as the anterior nerve of Latorget. So what I am doing is I am trying to cross over. So what we have to do, we will cross over the intercrural fibers. This is the right crust, and I am opening the left crust now. I'm trying to see the left crust, and between the two crura, you will see the esophagus will come. And these two crura maintain also the anti-reflux mechanism. I hope those who have seen the fundoplication, when we do fundoplication, this is part of the procedure because we have to mobilize the esophagus down around 3 to 4 centimeters and then do a wrap of fundal wrap. This. So what we are trying to see is we are trying to see the left vagus, which is anterior. So we will see the branching of this vagus, the left vagus. In a short while, you will see I will clear this some fat over there. Now you kindly see the anatomy, because laparoscopically you can better define this anatomy at the esophageal hiatus. This is the right crust. These are intercrural fibers. This is the left crust here. We will expose it. So you can see that we're trying to find out where exactly is the left vagus. So it looks like these are the fibers who are there. I'll go a little ahead to show you how the fibers look like. So possibly, yes, I hope you can see a cord-like structure here. This is the white structure cord. This is the left vagus. This is the anterior vagus. And you can see the branching of this vagus. We have we'll show you the branches of this left vagus. So you have to do we have done the right truncal vagotomy. We will do the left truncal vagotomy. I hope you can appreciate. So you see very tricky nerve. It will otherwise get lost, and you will not be sure what exactly. You may wrongly take a structure and call it a nerve, vagus nerve. So this vagus nerve is coming here on the anteriorly. It falls on the esophagus. This is very closely invested, the anterior vagus. Posterior is away from the esophagus. This is closely wed. That's how we differentiate. So this is here will be the left crust. So what we will going to show is that how does this vagus nerve branch here? Again, branches the same way. Now you can appreciate this is the vagus. I hope you can appreciate this is the vagus here going up. We will hold it with our left hand. Just now you can see we're holding it with the left hand, taking it up And you can see the branch. Now this is the celiac branch of the vagus that is coming on this. You can see the branching pattern. This is very interestingly shown here. See this branching pattern. So this vagus main trunk coming here. These are the two branches, and this is going ahead to divide into the gastric branches, and this will terminate as the nerve of Latorget. So we will clip them and then divide them. I'll just go a little ahead. You'll see we will clip them and then tease this to expose the left crust, because we have made the crura and the esophageal hiatus larger, enlarged. We have to do hiatoplasty. Otherwise, this patient will get hiatus hernia. So what we do is that after taking the left vagus, what we do with the clips, this is the harmonic, we are cutting the left vagus and sending it for biopsy to prove it that this was vagus only, this was a nerve only, not other tissue, soft tissue or anything. You see, we are taking a segment of this vagus, and then now after this step, we are searching. You can see the left crura. This is the esophagus down there. Now what are we doing? We have enlarged the hiatus. Can you see the hiatus? You can see this is the left crust and this is the right crust. So we are doing a cruroplasty. Otherwise, this big hole is the future hernia site. Anything can move up towards the chest and the heart hernia will occur. So we are taking a suture. We take a suture, a buttress suture between the right crust and the left crust to shorten the esophageal hiatus. So this procedure is also done, this hiatoplasty, when you do the fundoplication. This is also done there because you will have to mobilize the esophagus, so you have to add to this job of hiatoplasty. So you can see what we are doing is that we are taking the suture, and this knot which we are there is a sliding knot. So we are making that to just put a one hand, stop it there. The one hand has to be made, stationary, and the other hand you see, the suturing is very important. This is future of laparoscopic surgery. So all the postgraduates should learn on the simulator. You will not get time in your real time in the theaters to do this. So you should purchase the simulator. This is my suggestion to all the postgraduates, because you are the future for all of us. So to do this, you can see that we have put the two knots, and with the left hand is a sliding knot. We will hold it, and with the needle holder, we will take the knot down. We're holding the tail end, and then we will put this knot down. You see, this is the sliding knot, and it should allow, the hiatus should allow only this 5 mm instrument. That is all. Like in open surgery, we say only the index finger should go between the two crura. That is the rule in laparoscopic surgery also. And once you do this sliding knot, then you just put another knot and you go ahead to do this. So after this, you are cutting.
Excuse me. Sorry to interrupt, sir.
Sir.
Some of the doctors are not able to see the video.
Really?
Yeah, some. It was going on nicely, but maybe.
No, but is it moving on your screen? They may have the problem.
Yeah, I'm able to see.
But they have problem of their internet. Maybe
Vijayanand, can you update? Are you able to see? Dr. Vijayanand, are you able to see the video? Yeah, here the people are able to see.
Fine. Maybe a problem with, I feel sorry for them that they cannot see, because it is, if you are seeing, that means there's an internet problem. So can I resume?
Wait, just a minute, sir. Can you? Yeah, you can resume now. But
so now what I'm going to do is that after this, you have to add a bypass procedure. So this is the lesser sac, this is the stomach. So we have to do either a pyloroplasty or gastrojejnostomy. In this patient, you have to do posterior gastrojejnostomy. When you are doing vagotomy and for benign, the obstruction, gastric outlet obstruction, you have to do the posterior gastrojejnostomy. And when we do for tumors, we do anterior gastrojejnostomy. I think all of you know the reason why. So I'm cutting the gastrocolic ligament. I'm sorry. I'm cutting the gastrocolic ligament. Ibrahim sir, is it visible to you?
I am able to see, yes. I'm able to listen. It's visible also. It's getting demonstrated nicely.
Okay, I mean, there's no buffering with the video, no?
No.
Fine. So what I'm doing is I'm opening the lesser sac. You can see now the posterior surface of the stomach is exposed, and we will take the jejunum at the DG. This is the posterior stomach. We have to go to make the posterior gastrojejnostomy, not the anterior, because we are doing it for the benign pathology. So we will enlarge this around 5 to 7 centimeters of this. We expose the posterior wall of the stomach, and then I'll go to see the DJ. You see, this is the DJ, because how to go, you will retract the TC, that is transverse colon. You can see the DJ. So it is the DJ starts here. We will take around 15 to 25 centimeters. So each bite would mean around 5 to 10 centimeters. So we go ahead and take the loop of jejunum and make an anastomosis with the posterior wall of the stomach, the gastrojejunostomy. The first thing, we take the jejunum and the posterior wall of stomach. This is the anchoring suture that we have taken. So after putting the anchoring suture, we go little ahead to make the jejunostomy and gastrostomy. So this suture, putting the two together is very important, because your assistant is holding. You can see how he holds the jejunum up, so that you put the stomach and in line. They need to they have to be married together. And then you can see that once we put this anchoring suture, we will go to see that we will open the jejunum, and then we will use the stapler, that is the echelon endoflex. You will see it, and with that we make a hand seven, laparoscopic hand seven also, but it takes a little more time. So you can see we have tied the esophagus, this stomach and the jejunum together. I'll go a little ahead to show you so the jejunostomy is done. We are opening the jejunum here, and we will open the stomach also. You can see we are opening the stomach. We should make around 5 to 6 centimeter anastomosis, because the cartilage, that is mounts, makes an anastomosis of around 5 centimeters. So we are cutting the stomach, doing a gastrostomy. So once we cut the stomach, you will see both the openings. The jejunostomy is done, the gastrostomy is done. It makes life so comfortable. It takes just few minutes to do this anastomosis, which otherwise takes a lot of time to do it by suturing. If you do by open technique, so it takes time, and the blood loss is very less. The precision is there. ELS is less. You are properly handling only the structures which have to be handled. So after doing a gastrostomy, you will see now we are taking the endoflex. Can you see, this is the endoflex, echelon endoflex, and we are, we have to negotiate this is the anvil and this is the cartilage body. So we are marrying them together. So one end should be put in the jejunum, the other end is in the stomach. This is how we go, and this will make an anastomosis. So you can use either a green or a blue cartridge. You can see we are using a blue cartridge mounted, and put them together and then stay there for a minute. That is the compression time, which will displace the water content of the tissue away, and then we will stay religiously for 1 minute. That is the compression time. And the anastomosis, you will see just in a while, short while, you will see the gastrojejunostomy. It will cut and staple also, and so the job is done. So after this, we fire. If you are doing it with a manual gun, you will have to fire 4 times. So you can see the inside. This is the anterior wall and the posterior wall. This is now the gastrojejunal cave. You can see inside of the stomach. I hope you can appreciate the rugosity is there. This is the inside of the stomach scene. So we can see interior of stomach. We can see even the Riley's tube. We will tell want to put the Riley's tube. We can tell the anesthetist to put the Riley's tube and put it in the afferent limb. But in this patient, we have not put. But when we do it for tumor surgery, we usually always put a. So you can see the upper part of this surgery. So and we're just checking and then how do we close them? We close them by taking the V-lock. You all know is a barbed wire. It has made life comfortable for surgeons. In this patient, I am coming from below up. I suppose I have done from below up. So yes, so we are closing the jejunum. You see, we are taking the 2 walls together. And the idea to do it with barbed wire is that it is so comfortable, because you need not to hold the suture. It is it gets locked itself. So there is an eye. I'm passing the needle through the eye, and we are going to close this. I think yes. So I'll just take it ahead. You see, we are closing this common opening of jejunum and this together. So the gastrojejunostomy is done. You just see we have to make sure that the intracorporeal suturing has to be learned. This is important to do all the advanced procedures. Those postgraduates who want to see all kinds of surgeries like bariatric surgery, we are doing sleeve gastrectomies, we are doing total gastrectomy, we are doing partial D2 lymphadenectomies. You can go to log on to my channel. You have to just write Mushtaq Chalkoo in the YouTube, and you can see all kinds of different types of hernia surgeries, different types of GI surgeries, colorectal and gastric surgeries. We do bariatric also in between, but there's not much role of bariatric, so we don't get much patients, but there are few videos patients we have done bariatric surgeries also. You can watch them also, but there is a good amount of these videos are published on our channel. I would suggest all the postgraduates, this is important for them to go to the YouTube. You may not see all these procedures in the department, or maybe you may. If you don't see them, then it is wise to see them on the YouTube, because you are the people who have to do it in the future, Robert, because we are getting into the robotic surgery now. And that is why at the beginning I made a comment that the future surgeon is not a urologist, a gastroenterologist, or an oncologist, something like that. We will not be calling them by these names. I don't know whether this is my feeling. Will excuse me, the senior people are there, but I would say that, because if you are not acquainted with laparoscopy, endoscopy, and robotic surgery, the future surgeon's name will be laparoscopic endoscopic robotic surgeon, a laparoendoscopic robotic surgeon. He will be doing, everything. So if you are a master and you're trained and skilled, you can do all these procedures and give the benefit of minimal access surgery to the patient. So this anastomosis, the suturing is complete, and that's how it looks at the end of the day. The second layer we are taking, and this is done by, we use, if you're making this, you use it either 20 centimeter would be comfortable. You take 30 centimeter V-lock in the beginning, because the length of the thread will make you sometimes annoying for some surgeons. So it will be easy to make it with the 20 centimeter would be enough to close this. But if you are making all the anastomosis hands even, then I would suggest you take 30 centimeter length of the V-lock to do all these things. That ends it here. So I'll just come back to my presentation. So we were here. I was just trying to show you we were here. This is something very interesting, which is beyond surgery and laparoscopy, what we have been doing. I was a contributor to the local newspaper here, the Greater Kashmir, been a columnist for last 10 years. We were in between, if we get time, we keep on jotting some jottings, we keep on doing. Dr. Ibrahim, his bumpy roads is quite famous. So we have also given a try on a book on life, that is my expressions. This is not only laparoscopy, this is something what life is all about, and what's the idea of coming, and why are we here, why are we going back, why we keep on coming and going. This is the total life in totality. And this book we released in 2012 by the Vice Chancellor of the University of Kashmir. And this book is available. If you find time, you can go to see this book. And this is just 200 rupees. By cost, it is cost effective. This is what we have done. We have written 3 books by now. A book on life, my expressions. Pazar Aksun is my Kashmiri poetry. That is not available in the market, and most of you will not understand it. But this book can be taken and you can see. I would thank you all. I think I have crossed it 5 minutes more. I was given 1 hour show. Thank you very much. I believe in let us grow and let others grow with us. Thank you very much for giving me space and time. I am honored. I am thankful to the head of the Department of Surgery, Department of Yenepoya, for giving me space. My love to all the postgraduates and students, and regards to all other doctors whoever has joined this today in this evening. Thank you very much. I go back to Dr. Ibrahim.
Yes,
sir.
We have the honor of having Professor Musabba. He is our professor of surgery and head of and principal Yenepoya Medical College. Professor Musabba, sir, can we have some end note? Professor Musabba, sir. I'm not able to unmute him. He's probably getting some problems in this. If there are questions, kindly put.
Am I audible, sir?
Yes, sir. Yes, sir. Welcome, sir. Professor Musabba.
Thank you, sir. Thank you very much for your kind,
Yenepoya Medical College.
nice presentation. Very well. Sir,
Thank
when
you, sir.
you think that, when will you turn into the open? Is there any occasion you had in the laparoscopic surgery?
Sir,
Converting
we
into
should
the
not.
open one.
Sir, thank you for this is a important question to be taught to the postgraduates. I mean,
That is why
open
I'm
always has a place there. Sir, open always has a place, and we should not forget to train our postgraduates for open surgery. We should always keep in touch with the open surgery, because there are subtle instances for, I mean, the young surgeons, they will get stuck up even doing a cholecystectomy. Gastrectomy is part of a procedure. I mean, even doing a cholecystectomy, there are indications where we will have to convert. We call it as gold standard technique, but I believe sometimes you land up in such a situation like a frozen Pallet's triangle. You are not managing, or
Hello, sir.
you for the beginner. Hello.
Hello.
Am I audible?
Yes, sir. Yes, sir.
Audible, sir. Audible.
So, sir, your question is very valid. We should not. I mean, we have to get. I'll tell you that in Canada, currently what happened that when people started turning to laparoscopic surgery, everybody jumping into laparoscopic surgery. So they made mandatory for postgraduates to do 25 open surgeries. So it is reversed there. So the people have to get abreast with the open surgery also. So we should not lose the, I mean, the track. Even now, if I don't have an access to laparoscopy, I perform a mini lap, which we had shown in the beginning. I showed we have a very small 2 to 3 centimeter incision. We do a mini lap even for those patients who cannot afford, or who cannot, I mean, where the laparoscopy is not available. It's still far off in our countryside in India. It's still every hospital, small hospitals are not abreast with laparoscopic surgery. I think by there one can try mini lap and give them the equal benefit of laparoscopic surgery. But I think since our postgraduates, they are getting into laparoscopic surgery, it is also important for them to get acquainted with the laparoscopic techniques and laparoscopic surgery. But your question is valid, that they should not leave the touch from the open surgery.
Previously, we used to think that bigger the surgeon, bigger is the incision. But now,
so reverse, yeah, absolutely. Those do's and don'ts in Love and Bailey, I still remember chapter 3 and page 68. I still remember the do's and don'ts. They have changed. So you have to change with the times, and you have, that is, I mean, live with the fashion in the surgery. So the fashion today is laparoscopic surgery. So one is bound to learn it. But as the professor has rightly said, that we should not leave the touch with the open surgery, be it any procedure. One should know how to handle.
It is getting mingled. It is getting mingled. Now notes has come. Natural orifice transluminal surgeries, where we, as endoscopists, we try to invade the peritoneum and start doing the surgeries. Although it's
I will.
Far off track.
Absolutely, I will come back. I will come back to Professor Ibrahim. What he is saying that so what you are saying is the current mode of, I mean, for all the procedures, especially the GI surgery. Hello.
Yes, sir. Yes, sir. We are listening.
Hello.
We are listening, sir.
You are audible, sir. Audible.
Sir, I was replying back to your. I was replying back to what Dr. Ibrahim is saying, that, I mean, a surgeon, I strongly feel, should know also. Kindly go, please teach us the endoscopy, because it is very important when we are doing gastrectomies for the tumor. We want to know the proximal extension, distal extension. So a surgeon who is a laparoscopist should know the endoscopy also. But unfortunately, this domain goes to the gastroenterologist. Either they have to help us out, be on table with us, or teach us endoscopy kindly, because for the betterment of the patient, they ethically or oncologically safe surgery means the proximal margin and the distal margin.
Notes is an upcoming thing.
So I think endoscopy is very important.
Yeah.
Sir, notes, I'm coming to that. So what Japanese have done, Japanese believe in doing laparoendoscopy. So a surgeon in Japan who is a laparoscopist, because I was in Japan for some time, doing my fellowship in GI surgery. So what I found there, the surgeon there who does a laparoscopy does endoscopy also. So what they do is that endoscopically they see the luminal extensions of the tumor from inside and feed to the laparoscopist outside, because the laparoscopy the outside extensions, the endoscopy sees the inside. So if you marry the two, laparoscopy and endoscopy, I think you can do wonders. And this is the future of surgery: lapro, endoscopy, and robotics. That's why I kept on saying in between that the future surgeon is none. He is lapro endoscopic robotic surgeon.
Another dimension to add to your thing will be that another dimension which has come up recently is the interventional radiologists. So if you have a CLAT scan,
very true, sir.
Yeah, they can go by the stent placement and do the palliative things, because now the
absolutely so.
Exactly.
Absolutely so. I tell you, we are so we are I tell you, sir, we are getting jealous of them because they are taking all the work of surgeon. So everything is getting into interventional now.
Basically,
Even the gastroenterology is
interventional things are
yeah,
going.
it is a, I think the germ of surgery is entering into the medical medicine also. So you know everything, be it gastroenterology, be it radiology, be it urology.
Exactly.
So interventional part is always for the betterment of the patient, right, sir?
Professor Musabba, sir, is there any further query to Professor Chalkoo?
Sir, very nice
I
talk,
would like
sir.
to know.
Once again, I thank you very much, sir. Am I audible?
Thank you very much, sir.
Yes, sir, you are audible.
Yes.
Okay. Now, for the golden procedure for the laparoscope beginners is the cholecystectomy, of course. But there is one thing who are entering into the laparoscopic surgery, they should also remember the anatomical variations. In gallbladder surgery, there are so many anatomical variations. If they are not in touch with that one, it will be end will be very disastrous. If the bile leak occurs, it is a one of. So in a surgery, there is a one saying that A into P is equal to constant. That means if anatomy is good, pathology is less. If pathology is more, that means the anatomy is obscure. So we have to understand the anatomy of the biliary system very thoroughly before practicing the laparoscopic surgery. That is my advice to all the people.
So nice of you, sir.
I agree.
If there are any more questions, if there are no questions, we call it as segment.
Sir, are there any questions from the postgraduates? Any query, any clearances they want?
If there are no questions, sir, should we conclude it then, Professor Musabba?
Sir, once again, I very thanks to you because you arranged it. I don't know. In the last moment, I came to know that such a talk is there. We are.
Thank you,
sir. Is the Kashmirian, I think, isn't it?
Sir?
Sir? The Mushtaq sir is the Kashmir from Kashmir.
Yes, sir. Yes, sir.
Yeah.
Professor Mushtaq.
In the Yenepoya Medical College is having very much connection with the Kashmirian people.
Yes,
so many postgraduate, so many staffs, and even our previous principal, Dr. Jilani, is from Kashmir. And
yes, absolutely.
We are very much thankful to you, sir.
I'm also thankful, sir, for listening to me and giving me a chance to interact with the students. Thank you very much once again, for being kind. I'm also Dr. Ibrahim provided a platform to get me interacted to the students. Thank you very much.
Thank you. Thank you, sir. Thank you, sir.
Thank you very much, sir. Thank you, sir. Thank you, Professor Chalkoo. Thanks for having us, having you here. Thank you very much. I end it.
Okay. Thank you.
Thank you, all of the students.
ക്ഷമ ക്ഷമ നിന്റെ ലാപ്ടോപ്പ് കൂടെ വേണോ? അല്ല എനിക്ക് വേണ്ട, നിനക്ക് ഇവിടെ ഇരിക്കട്ടെ അല്ലേ? അപ്പൊ ഇരിക്കട്ടെ, ക്ലാസ് ഉണ്ടാക്കാൻ നല്ലത്. ഇവിടുത്തെ ഇതൊന്നുണ്ട് പോലെ കുഞ്ഞിനെ ഇതാക്കണ്ട ചുറ്റൂരാ. അതാ കുഞ്ഞെ ചുറ്റുൻ്റെ അകത്ത് കളിക്ക്. അത് പൊളിക്കലാണ്, അത് ഇതല്ലേ ഇതല്ലേ കുപ്പിയല്ലേ, പൊട്ടിപ്പണ്ട് കുപ്പിയല്ലേ. കൊടു ആ സോട് കൊടു, സോട് അജ്ജുണ്ട് താത്ത. Answer into their ഇതാ കുഞ്ഞെ, ഇതാ ബാഗ് കൊണ്ട് പോണ ആ ബാഗ് കൊണ്ട് the books are all good. Amma, the book complete പോയിനാ എങ്ങനെ പോയ book my books huh? My books surgery books diagnostics books are cool, போயினா அது சர்ஜரி புக்ஸ் ఓకే అందరి బుక్స్ ఉన్నాయి Correct, sir. Correct. Two things, that is the mucosal resection and endoscopic submucosal dissection. These are the two terms in the advanced colonoscopy. And endoscopy. Advanced endoscopy. Once in technique one, endoluminally by two endoscopic mucosal resection. And another one is the endoscopic submucosal dissection. An advantage of submucosal dissection, polyps and large intraluminal lesions are removed in en bloc. Picture house for more precise histological and technically difficult. The use of these approaches will in all likelihood expand. Procedures will be more commonly performed with large intraluminal in the future. So these are the two advances, therapeutic advances. This normal biopsy and all these things. These are the two things: endoscopic mucosal resection and endoscopic submucosal dissection. These are the endoluminal approach we can make. In endoscopy technique to hand and in instruments in endoscopy. To be successful in gastroenterology endoscopy, currently available tools and endoscopy systems. Chapter will review the different types of endoscopic equipment necessary to advance surgeons about the best application of the types. Discuss different types of colonoscopes, snares, and needles, carbon dioxide insufflation devices, methods of chromoendoscopy. That is another thing is that the traditional flexible endoscope is equipped with an instrument or biopsy suction channel, instrument suction channel, extending from the entry site of the biopsy port to the tip of the instrument. Usually about 3 mm in diameter. Channel and insufflation channel. There are two channels: biopsy channel and biopsy suction channel. And insufflation or suction channel into the entry site of the suction and inflation. Separate and suction on the channel. 3 mm in diameter, but varies from 1 to 1.5 millimeters, for which diagnosed neonatal reduced. Separate air and water inflow separation permit distension of the bowel. Air and water insufficiency. Air insufficiency of the bowel and cleaning of the lungs. During colonoscopy, the biopsy suction channel. Biopsy and the suction channel. Water and air. And the biopsy and suction channel generally operated at 6 o'clock orientation. So usually biopsy section channel is trachea allows the fluid that is pulled by gravity to be suctioned easily. The easier manipulation of the fluid perception snaps. The most flexible endoscope is 100 to 160 centimeter. That is the. But there is a air and water insertion. And suction channel is there. That is the two. Usually they are used. Endoscopic instrument, biopsy port. Is the biopsy port is there. Manipulation of the biopsy port. 6 o'clock. The biopsy port to the 6 o'clock position. 6 o'clock position is the ideal one. I think this one is. Optics are there. Light is suction port. Working channel. Correct. Good. Need for further improvement in endoscopic technique. 2-channel video endoscopy. Two-channel endoscopy. Scar can be both crossing goes and scar can be inserted into the bone at the same time. Two-channel endoscopy. Further endoscopy two-channel video endoscopy. Video endoscopy is two-channel for the biopsy, and we can also have the snap. There are two instruments. Acceptance snap, grasping instruments also. And it creates the traction, the snare and the traction. Dual channel scopes are there. Dual scope are there. So many instrumental. So double channel. Third eye endoscopy. There are two cameras.
Tell me where's the big phone.
Oh. പിന്നെ പോ നാളെ പോ. എന്ത് എവിടെ പോണാ ഇത് ക്ഷമ എന്റെ വിളിക്ക് പോണ്ടല്ല എന്റെ വിളിക്ക് പോണ്ടല്ല ഞാൻ വന്നു കൊടുക്കുമ്പോൾ
പണിയെത്താ താഴെയുള്ള
الله أكبر الله أكبر الله أكبر الله أكبر أشهد أن لا إله إلا الله أشهد أن لا إله إلا الله أشهد أن محمد رسول الله أشهد أن يا للصلاة يا للصلاة يا للفلاح يا للفلاح الله أكبر الله أكبر
Good job. Good job. Ba. 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 Ba udah. Ba cici ba.
reliable setup. That's one saying. If you don't eat, don't sit. If you don't sit, you die. If you don't, it's the same. If you don't eat, you don't sit. If you don't sit, you will die. That is the same.
stitches inside. And see when